Hi, Anneke.
Hello.
Good evening. Nice to see you. Thank you very much for those two talks, really giving us a good overview of the work that you've been doing on Lederhoser. First question from the audience from Wolfgang Wack, who is from the International Dupuytren Society. Two questions really on your first talk about the LTE study. Was this a retrospective evaluation of the treatments, or did you sort of collect a retrospective cohort and then go and follow them up?
Yes, it's correct. It's retrospective. So we did not have the patients in a follow-up schedule and did not collect at several time points. But we collected retrospectively the pain scores. So that's certainly a limitation of this trial, and that's why it's still not sufficient. But we think it is hopeful because patients are also very satisfied about still many years after treatment, satisfied with the result and have low pain scores actually when we ask them to complete the questionnaires.
Okay, and a second question from Wolfgang about the same study. It was something that I noticed as well. 43% of your patients seem to find the treatment burdensome, as in only 57% found that it wasn't burdensome. Why was that?
Not sure, because it was a multiple choice question, which ranged from if it was burdensome, somewhat burdensome, or but I think that we did not look into that any further, but maybe because patients have to visit us 10 times to complete weeks, and there is a couple of weeks in between. In the Netherlands, there were not that many institutes offering the treatment. So sometimes patients come from over the whole country to Groningen to get the treatment. So maybe that's why it was for some patients burdensome.
Okay. We've got another question from Lisa Lichtenstein, which is a good question. In Lederhosen in general, is it better to treat early in the disease or better to have a watch and wait approach to make sure it's active and progressing in some way?
Well, in our study, we did not distinguish between early stage or late stage. It was mainly the pain score, which was very important. So patients at least needed to have a pain score of 2. We had some patients who were just diagnosed with the disease, but also patients who already had the disease for many years. So I cannot say anything about what's better. In our study, it are patients from all phases.
Richard, while we have you on the panel as well, what's your thoughts on that with a more sort of general overview rather than just from the study?
Well, I think one thing that's really interesting is if you treat very early patients, you would expect 20% of them to get regression of the nodules and pain anyway. And, I was struck particularly by the high placebo response in your study. And I do wonder, obviously we haven't seen the whole breakdown of what stage people were at in terms of what the duration of their pain or the nodules was. But, I can imagine if there were a lot of very early patients that might have accounted for some of the placebo response. I mean, personally, if a patient has just noticed the nodules, let's say, a month or 2 or whatever ago, I would tend to leave them and see whether perhaps things either stabilize or, you can use conservative treatment to take the pressure off the nodules without actually irradiating them. I guess there is some evidence to show that if you treat early, you might get a better response. But on the other hand, you can treat patients very late on, and I've seen excellent responses late on. So my rule of thumb is, if they've had discomfort for more than a few months, it's not going away, conservative measures aren't working, or they've got growing nodules that are causing problems due to bulk. So that's, and I'm sorry to make a long point, but I'm also going to be very interested to know about nodule size as well, because for some patients, actually, pain is the problem. For some people, it's a bulk issue. And I guess the last thing that I would say also is in terms of the placebo response, there is studies from the US looking at some MRI measures, and sometimes even though the nodules don't change in size, actually some of the T2 characteristics of the MRI scans can change. And I guess one thing I'd be really interested to know is, why do people get such a placebo response? Is it truly just some sort of psychological phenomenon, or are there some actual physical measures, something that you can see going on? And I think that would be really obviously once we see the full data in the publication, just something I'm very struck by that high placebo response, be like highly interested to see all of that. So, but I think it's an incredible study, really very useful and interesting. So thank you.
Anneke, could you comment on the placebo response? Because Wolfgang has also asked a question about that in the Q&A. So what are your thoughts on why you might have seen such a large placebo response?
Yeah, it is very difficult. We all know how difficult the placebo effect is. It's described very often. We have to investigate. We found that there was a large improvement in pain in the first 6 months. So, and it was the same as in the radiotherapy group, and then it stabilizes. Actually, at this moment, I cannot say anything. We are still working on the data.
Well, I'm sorry to interject again, but one other interesting thing about the placebo response is there was the same reduction in pain between the sham radiotherapy and the radiotherapy group, but actually the increase in quality of life was significantly different between the radiotherapy and the sham radiotherapy group. So there's a disjunct there. If there's not a difference in pain response, why was there an increase in quality of life in the radiotherapy compared to the sham group? That, to me, there's something else going on, I think.
Yeah, but
interested to know what you think.
To comment on that, what we saw for quality of life was that the mean score for the radiotherapy group was already lower for the radiotherapy group than for the placebo group. So there was a bit of a disbalance. But then indeed, the improvement in the radiotherapy group is significantly more than in the sham radiotherapy group. Yeah, so we also found those results very interesting and promising, because we hope that together with the results for the pain and the quality of life, that will be that we can convince the health insurance companies that it is effective, despite the placebo effect.
Yeah, I think your cost effectiveness analysis will be key there. Certainly, if the UK is anything to go by, that will be the important one.
Yeah.
Anna Shura from the British Dupuytren Society would like to ask you, you had more female patients than males in both of your groups in your randomized control trial. Does this fit the demographics? I guess that's relating to Dupuytren's disease, which is more common in males than females.
Yeah, actually, if you when you see the literature, it is often described that more males are affected, but yeah, in our study, more females were included, and also more females came to our institution and the participating centers with their disease. And yeah, I'm not sure if that's because females are more willing if they hear about a trial or that there is an opportunity to get treated, that they are more willing to come. Not sure, but it was, yeah, we also found it interesting that it was the other way around than in the literature.
Yeah, so interesting observation. Henry Weatherburn has a question about follow-up. Are you extending the trial to look at longer-term outcomes in this in these two cohorts?
Yes, we have a 5-year follow-up in our clinic. So at 18 months, patients are unblinded. So then they will know the treatment arm. Patients treated with radiotherapy will be followed every year until 5 years. And after 5 years, we will do a follow-up by phone. And the patients who were treated with the sham radiotherapy get the opportunity to be treated with radiotherapy. That was something the ethical committee requested.
Yeah.
Some patients who are doing very well at 18 months and got the placebo are followed as placebo, as placebo patient in the long follow-up. And patients who still had a lot of pain, they took the opportunity to get the treatment, and we followed them in a second period of the study. We extended the study with a second period, and then the treatment, the follow-up schedule is again the same as in the main trial. So at the end, we will have a large cohort of patients treated with radiotherapy.
Perfect. There are a few questions from Professor Siegenschmidt. Did you do individual planning for different foot sizes and depths of lesions depending on the thickness of the lesion, or was it just all completely standardized?
It was standardized.
Okay, and did you use, I guess this relates back, and the answer is going to be no, you didn't use MRI for more complicated patients in order to help with planning?
Well, if we had an ultrasound and an MRI in our study, so those were done, that's also one of our secondary outcomes we still need to work on. At baseline and 12-month follow-up, imaging is done. And if we were not sure, every patient got those imaging, but if we were not sure about the disease, we asked the radiologist to mark the nodules on the sole of the feet, and then immediately after the patient came to us so that we could delineate the treatment fields. So then we used the imaging. Yeah.
And there's a 4-stage classification system for Lederhose disease. I guess this relates back to what Richard was asking you about. Did you use that classification, and how well balanced were the groups and things like that?
No, we did not use that staging, but we stratified for gender and age in the randomization. So that was balanced, but not the disease stages. Okay.
That'll be interesting to see how that comes out in the paper. 2 more questions. This might feel like your PhD, Viva. Maybe it's good practice for that. Why was the use of superficial X-ray treatment discontinued in favor of electron beam treatment?
Can you please repeat that question?
Why was the use of superficial X-ray treatment discontinued in favor of electron beam treatment? Maybe does that relate to a difference in the radiation that you delivered in the 2 arms of so in the retrospective study versus your RCT, or were they both the same?
They were both the same, but
Anneke, you started with orthofold. You started at orthofold and then you continued with electrons. And why did you change from one to the other?
Because of, I think, different insights from the radiation oncologist and the availability of the device. But in our trial, in the lateral trial, the randomized control trial, it was done with the electrons. Yeah.
I guess you had to choose one to make it standardized.
Yes, that's correct. Yeah.
Final question, I think, from Wolfgang. He said maybe the walking in being much better in the radiotherapy group could be at the root of that great improvement in quality of life. What do you think about that? That the quality of life and the improvement in walking abilities is related? Is that the... Could be, yeah. So maybe they're correlated, and that's the reason why, despite not having such a great improvement in pain, still the quality of life went up. by 6 months?
Yeah, that might be the main symptom of patients is the pain, and that can be very disabling, but also the impact on, of course, on walking, on running, standing can be very large. So if patients can move, walk better, yeah, then they might be satisfied about the effect, and that it is a gain for the quality of life, that they can move around and do more than before.
Yeah, it may be an idea to look for a correlation in your data there.
Yeah, that's interesting. Yeah.
Good. I think we have covered everything. So all that remains is for me to reveal the winner voted for by some of the organizing committee. And I'm pleased to say, Anneke, that you have won the prize for the best presentation. And it's for your randomized controlled trial. Really great to see such good, high quality work, giving us good evidence. And we're all going to look forward to the publication of that paper. Congratulations.
Thank you.
Excellent job. You had a lot of questions to answer as well. So well done standing up to scrutiny. That's very good indeed.
Good practice.
There is, yeah, good practice. There is a prize and we'll sort out a certificate for you. I'll email you about that afterwards. Thank you to all of our speakers tonight as well. Thank you, Richard, for being our keynote presenter. Thank you to Jared for presenting the early results of a randomized controlled trial as well. It was great to hear about all the work that's going on in this area. Really excellent symposium. Thank you to all our attendees. And we look forward to seeing you. Please register for our next symposium in 2 weeks' time, which is going to be looking at outcome measurements in Dupuytren's disease. Thank you, everyone, and good night.